This program is brought to you by Emory University.
Good morning, everybody. Welcome to Friday morning Fellows Conference. As you can see, this morning is a journal club. We have two presenters. Our first presenter will be Dr. Annie Ho. Annie is a second-year fellow in the clinical track, Florida native, did her residency here at Emory, and she is going to talk about the Revived trial. It was in the New England Journal of Medicine. Dr. Ho, take it away.
Thank you. Good morning, everyone. Thanks for coming to Journal Club. Okay, as Dr. Williams stated, I'm going to do the revascularization for ischemic ventricular dysfunction, or AKA the Revive trial. And then, okay. I have no financial disclosure. And then this is just kind of the title of it. The article has been a hot topic and created a lot of buzz since its publication in the New England Journal on August 27th of this year, a couple months ago. I think it's an interesting article to discuss because it may be practice changing, and not for, spoiler alert, I'm sure a lot of people have already heard about the article or seen it on Twitter and read, or maybe read it already. But the headline is, PCI is not better than GDMT in ischemic cardiomyopathy with low EF. I put a QR code here for the article. I'm sure everyone kind of is familiar with QR codes now this late in the pandemic. So you could just take your camera out and then it'll take you to a link. You may have to sign in with your email information to the Emory library. I'll give everyone a few seconds to scan. Okay. So to start, I want to talk a little bit of background about what we know, or what's the point of, talking about revascularization when it comes to ischemic cardiomyopathy, with the context of CAD can theoretically result in hypernating, the theory of hypernating a myocardium, which is just chronic myocardial contractile dysfunction due to chronic ischemia. So the theory is that, you have reduced blood flow to the myocardium, and so then increasing myocardial demand and resulting in impaired contractility. And the hypothesis is that if we reverse myocardial hibernation by coronary vascularization, whether that be CABG or PCI, it's possible that we can improve outcomes. Now, this is still debatable, and there's still limited evidence on whether PCI, in addition to optimal medical therapy, is superior. So this study kind of puts into question if this theory of hibernating myocardium hypothesis is correct, and if we should routinely look for ischemia when we diagnose with patients with new congestive heart failure with low EF. Sorry, my screen is frozen. There we go. So the question is whether revascularization by PCI can improve event-free survival and in patients with systolic dysfunction and low LVEF with severe ischemic cardiomyopathy compared to, so PCI plus optimal medical therapy compared to just medical therapy alone. Okay, so this is a prospective multi-center randomized open label clinical trial. And there was about 40, at the end of the study, about 40 centers involved. And every center had two leads. One, that's the PCI lead, and then one is the heart failure lead. Recruitment started back in 2013, ended in early 2020. And then the study actually ended in March of this year. So they randomly assign on a 1:1 ratio patients with heart failure or with the LVEF less than 35, and then extensive CAD. And I'll go into more details of how they define extensive CAD. And they have to demonstrate that there's viability in at least 4 segments. And then I'll go into also the exclusion and inclusion criteria in a second too. So this is just kind of like the timeline of when the study started, when recruitment ended, and then when follow-up ended. Okay, so inclusion. You have to have your EF less than or equal to 35%, and that's via cardiac MR or echo. You have to have extensive coronary artery disease, and they use the British Society Jeopardy score as a marker for what counts as extensive coronary disease. So you need a score of 6 to get in the trial, and the max score is 12. I put a little QR code there if you want to read more about how they validated this scoring system, and 6 would get you in the trial. So if you scan your, same thing, take out your camera and scan it, and it should take you to the article. Next thing is that you have to demonstrate that there's viability in at least 4 dysfunctional myocardial segments that's amenable to revascularization, and that's done by either cardiac MR, SPECT, PET, DSE. So of note, the exclusion criteria for this study is that you could, basically you can have any like very recent cardiac events. So that includes acute MI in the last 4 weeks prior to randomization, because then that puts you in the cardiac stunning phase instead of hibernating. And then acute decompensated heart failure, or if you've had a sustained arrhythmia in the last 72 hours prior to randomization. Okay, this code will just take you back to the article. So if you want to scroll to table 1 to kind of look at the baseline characteristics. So in summary, important things to just, I'm gonna read out is median age is about 70 years old. Mean LVEF is about 27%. Again, that's via echo or cardiac MR. The median Jeopardy score, British Jeopardy score, where they classify the extent of CAD, is about 10. And remember, 6 gets you into the trial, and then the max score is 12. They included, interestingly, in this study, is that they did include left main disease, about 95 patients. And then most of these patients are on pretty good GDMT. So about 90% of the patients were on beta blocker, 90% were on ACE, ARB, or ARNI. About 25%, 50% was on MRA. 25% had already had either a ICD or a CRTD. And of note, SGLT2 inhibitors came at the end of the trial, so you won't be seeing that data. But before I go to the results of the trial, I wanted to bring up 2 landmark trials that also looked into revascularization for patients with LV dysfunction. So the first one I want to talk about is the SITCH trial that was done in 2011. And basically, as among patients with ischemic cardiomyopathy with low EF less than 35%, less than or equal to 35%, does optimal medical therapy plus CABG improve mortality compared to optimal medical therapy alone? And they randomized, and this study was done between like 2002 and 2007. There's about like 1,200 patients totaled, and then that were randomized. So the primary outcome of death at any cause is pretty much the same in between the 2 groups. So did not improve death, and that's at the mean follow-up year of about 4.5 years. There was no difference in primary outcome when you compare the 2 arms. Interestingly, follow-up data at 10 years did show a reduction in all-cause mortality in the CABG plus medical therapy arm compared to just medical therapy alone. Okay, I did want to bring this up because this is surgical revascularization, and the REVIVE trial is talking about PCI revascularization. The other thing is that this study did not look into viability, whereas REVIVE did. And then the SIS trial also excluded critical left main disease, whereas the REVIVE trial did include close to 100 patients. And then there was also the CAST trial back in 1985 that also demonstrated no overall survival benefit for CABG patient compared to optimal medical therapy alone with patients with stable CAD. They use like dysfunctional EF of less than 50%, but among the data among the patients with more severe reduced EF less than 35% was limited in this study. Okay, going to the results portion of the REVIVE trial. So primary outcome looked at all-cause death or hospitalization from heart failure. And basically, the outcome for both arms is the same. And then secondary outcome, they looked at two main things. One was quality of life, and they used the Kansas City Cardiomyopathy Questionnaire, which I linked a QR code at the top corner, as you could see. And if you scan it, you should be able to go and see like the little PDF for the questionnaire. So they used the questionnaire to determine the quality of life. And they did that at 6 months and 12 months, which did show an improvement in the PCI group, the PCI plus medical therapy group compared to the medical therapy group alone. However, it did diminish at 2 years. And then the other secondary outcome they looked at is LVEF improvement in the two groups, which was basically the same, or there's no improvement in both arms at 6 months and at 12 months. And they did using like echo and cardiac MRI. Okay, this is just a schema of looking at the primary and the secondary outcome as we discussed. Here, this graph shows the composite outcome of death from any cause from hospitalization for heart failure over the 24-ish month follow-up period. And as you could see, it's the same. Okay, so this is looking at table 2. If you pull up the article again, then you could see the table for the outcome. So again, about 700 patients were randomized. Average LVEF is around 25%. The median follow-up duration was about 41 months. So ranging from 28 to about 60 months after randomization was the follow-up. And then they looked at the composite primary outcome. So in terms of death or heart failure hospitalization, PCI about 37-ish%, and then optimal therapy alone was about 38%. So no difference in the individual components of the composite outcome. And then looking at the secondary outcomes, they looked into the LVEF to see if there's any improvement, and there was like less than 1% difference in the EF. And then the quality of life score did favor PCI initially for the 6-month follow-up and 12-month follow-up, but then there was basically no difference. It diminished after 24 months. Okay, so basically, this is kind of the author's conclusion. Like PCI does not reduce all-cause death or hospitalization at a median follow-up of 3.4 years. The reason why I bring up the 3.4 years is because if we look back into the this Stitch trial, that at follow-up at 4.7 years, there also wasn't a reduction in or in death, but later on at 10 years, there was a difference. So patients with severe left ventricular systolic dysfunction, extensive coronary disease, and dysfunctional but viable myocardium in addition of PCI to optimal medical therapy did not lower the incidence of death from any cause or hospitalization for heart failure, and the improvement in the LVEF. So this is looking at the median of 3.5 years. Interestingly, again, this is 3.4 years now. So we don't know what the data is going to look like in 10 years. Okay, some strengths of the study. I think that it asks a very clinically important question in a high-risk group of patients. The groups were fairly balanced in terms of age, race, BMI, the New York Heart Association functional class, Canadian Cardiovascular Society angina class, and then in terms of the GDMT that they were on at baseline. Almost no loss to follow-up, 99% has been evaluated for primary outcome. And then all hospitalizations for heart failure were educated in the blinded fashion by independent event committees. And then also the LVEF was assessed in a blinded fashion at the core lab as well. Some limitations. Sorry, I think my screen is a little frozen. Okay. It is an open label trial, so it's unblinded. So the study designs can impact subjective outcomes such as quality of life for these patients filling out the Kansas City cardiomyopathy questionnaire. Most patients in the trial, interestingly, I think over 70% had class 1 to 2 New York Heart Association angina score. And it's also important that these patients were not like admitted to the hospital and then like underwent cath or revascularization. These are fairly stable patients, because remember, some of the exclusion criteria is that you couldn't be in acute heart failure, didn't have a recent ACS event, and didn't have any sustained arrhythmias in the last 72 hours. So fairly overall stable patients. Okay. 90% of these patients were Caucasian, which could limit our generalizability for especially in our patient population here in Atlanta. And then the primary outcome was a composite outcome that were not of equal value. So like hospitalization versus death. So, and, there's also into question, the complexity of the coronary disease in the trial population. So we don't know what was intervened on. There was a small percentage, so 95 out of the 700 patients had left main disease, but only 50% had two vessel disease. And then the British Society Jeopardy score was, there's a question about if it's been externally validated as well. The other thing to note is that the data from ICD was not reported. So, in terms of arrhythmia or sudden death. Okay, so I wanted to leave a little bit of room for discussion because I know this is a hot topic and everyone, wants to put in their 2 cents, but I do want to bring up what's so interesting also is in both arms, in the PCI and medical optimal therapy arm, and then just the optimal medical therapy arm alone, both did not show an improvement in your LVEF at follow-up. So that's interesting to me. I'm going to open the floor to discussion.
Hey, Annie, this is Manj Okadar. Good job.
Thank you.
This is an interesting paper, but to me, it doesn't answer the question. And let me elaborate. I think we need to differentiate between viability and hibernation. And these two are conflated in many landmark trials, including Stitch 3, this study, and others. But if you look at the original descriptions by Rahimtullah and others 30 years ago, there's a very clear distinction between viability and hibernating myocardium. So hibernating myocardium is myocardium that's alive. It doesn't predict whether or not that myocardium is going to recover or improve with revascularization. Whereas viable myocardium is myocardium that will improve with revascularization. So those are two separate entities. Now things like nuclear scans, PET scans predict hibernating myocardium, but only things like angina, increased contractility post PVC on ventriculogram, a biphasic response on dobutamine. Those are things that predict viability, meaning recovery of the ventricular function with revascularization. And it's well established that the longer someone has hibernating myocardium, the less likely that hibernating myocardium will be viable. And these folks, as you pointed out, are long-standing ischemic cardiomyopathy patients, stable. So they're at baseline, they're not likely to get better, period, just from the chronicity of it. Other things are, angina. I mean, I think angina is a very important thing to consider for these patients. If someone has angina, I think you can, that bolsters the idea to revascularize someone who has ischemic cardiomyopathy. So those are my 2 cents. And this study, again, they put all in the same pot: MRI, DSE, and nuclear hibernation testing. I don't want to use viability testing because those are two separate things. So those are my 2 cents on the topic. But thank you again.
Mon and Annie, I want to clarify something Annie had touched on with the angina, and Mon mentioned too. Actually, if you go back and look, 98% of the patients had class 2 angina or less. Like, I think it was 2% in both groups had class 3. So this group had very little angina baseline, as Mon was saying, and Annie, you mentioned too. So I mean, if you're going to get a benefit in these groups, it would be people with angina. And it's always sort of, I remember being told by folks, and as your LV function declines, typically your angina often gets better, even if your coronary disease doesn't. And sort of these groups are sort of are a proof of concept of that in a lot of ways. How little angina that these groups with reduced LV function and severe coronary disease, how little angina they actually have. And so that improvement in quality of life that wasn't durable, you wonder how much of that was placebo effect potentially, given that this was unblinded, or a real, temporary improvement in angina, maybe. I don't think the authors sort of went into that much in their discussion, if I recall. But my take on this, and Mon's right. I mean, a couple of things. One is our assessment of viable myocardium is very difficult. It's a very difficult thing to do and control for. And number two, to me, I would have been like shocked if this percutaneous intervention on stable outpatient coronary disease with minimal angina had showed any sort of substantial improvement in mortality or hospitalizations, personally. So I think it's sort of, I don't know. If you look in the chat box, Dr. Morris had made a point. I just want to bring that out. Like, it did show that there is relatively rapid improvement in folks' status with GDMT as opposed to long term. So anyway, I saw Dr. McDaniel unmuted, so I'll let him talk.
Well, I agree with those thoughts. I will say though, every time I've asked somebody, is this, was this surprising to you? No cardiologist has said this is a surprising finding, yet it's exactly opposite the way most cardiologists practice. I would say that there is a very gut reaction when, or maybe not cardiologists, but physicians in general, they make a diagnosis of new onset cardiomyopathy. The patient doesn't have angina, and they go straight for an ischemic evaluation of some sort to go look for ischemia, with the idea that if you find multivessel coronary disease, that if you revascularize the patient, that you'll improve the LV function, and thus that will improve the mortality of the patient. And I think it's very common practice. I'd say that that's the norm out there. And I think that this and Stitch and some of the other CTO, revascularization trials really questions that paradigm. I would agree with you that there's some very different difficulty with, evaluating hibernation versus viability. But I would say in clinical practice, we just aren't able to do that assessment well. And I think what this does suggest is that we should probably be a little bit more conservative up front at the initial stage of diagnosis and not rush to make diagnoses of coronary disease without those higher risk features, without ACS, without angina, without something like that. Because if you put patients on meds, their EFs may improve, with just meds. And then if you decide to do an ischemic evaluation down the road, you may come up to different conclusions about what needs to be done if you do this later on with a different EF than you do up front. So I think that we can make some wrong decisions for our patients by being very early with our diagnosis of coronary disease uniformly. That doesn't mean we should never do it, but I think uniformly doing ischemic evaluations is probably the wrong thing to do. And then I think lastly, we should probably not use nuclear stress testing to evaluate for, cardiomyopathies in general, because it's for the issues that we can discuss. And lastly, I think that really the most interesting thing from these findings is that in neither Stitch nor in Revived did the revascularization improve the EF. So, we always say that these are ischemic cardiomyopathies because we find cardiomyopathies in multivessel coronary disease. And I think that maybe we should not jump so quick to make that distinction. And we should just describe these things a little bit better as just cardiomyopathies and multivessel coronary disease, but not necessarily saying that the ischemia is the etiology.
Hey, Mike McDaniel, this is Mon again. So I don't think that answers the question. So this group was chronic ischemic cardiomyopathy. If you have new systolic heart failure, I don't think this study answers the question about whether or not we should do an ischemic evaluation. I don't think that's applicable. So now it's not clear to me that we have those data that does an ischemic evaluation when someone with new onset heart failure, systolic heart failure, is that the right thing to do? I don't think this study does not answer that question.
I agree, but it should question it.
Long-standing is very different. Oh, absolutely. I agree. It should question it, but I don't know that it changes at least my practice yet.
Dr. Smith. Sorry, guys. I'd want to let some other folks get their licks in. Dr. Smith and Dr. Dickert have their hands up too.
Yeah, just a comment about the long-term Stitch follow-up, which later showed improvement, was, some of the thought behind that was that you had lost some patients from the surgical procedure early on who died from surgical complications, and it just took a while for the benefit of surgical revascularization to catch up. And I guess in this study, there probably wasn't a high operative procedural. So I would be a little bit suspicious as to whether the long-term follow-up on these patients is going to show benefit. But very interesting study. In my practice over the last 3 decades, I haven't gone and searched in detail for ischemia viability and that sort of thing in patients who did not have angina and had long-term ischemic cardiomyopathy. And just, it's also been somewhat rare to see acute myocardial infarctions in these patients. They often, the ones without angina don't just show up with an MI out of the blue for whatever reason once they're on standard therapy. But just the importance of our medical therapies are just showing to be better and better. And we have to look at what we're doing with revascularization. We have to look at what we're doing with ICDs.
Dr. Dickert.
Yeah, so just a couple of real quick things. So to piggyback on Andy's comment, I think I also would not be optimistic about the longer term follow-up, in large part because the crossover is going to be substantial in this case in a way that it wasn't in Stitch, right? So people can easily go in and get a PCI if their symptoms worsen, and you can see that already in this, that you had a number of people who crossed over to PCI during the follow-up period here. So that's going to be a bigger problem in terms of interpreting any long-term follow-up. The second piece, I think, with regard to the acuity, Annie, you may have data on this, but with Mon and Michael were talking about this. I actually don't think these were necessarily long-term heart failure patients. I don't know how much that was presented in terms of the duration of heart failure. They excluded people with acute MI or ACS, but I don't think they necessarily had to have what we would call years and years of heart failure. So you may have some information to add on that. The last piece I know, I was, just to look at the editorial to see sort of what people focus on in terms of things to pick on. The one thing, some of the accompanying editorial, I wasn't persuaded by some of the points, but one that I do think is interesting. We always have this question of heterogeneity, right? Someone has a very large territory with a big LAD lesion versus, multiple vessels with still things that look like they might be helped, but this is a heterogeneous population. And I do think there's some interesting questions about whether there are, in a trial like this, the ability to pick them up is going to be hard, but there's a little bit of patient specificity in terms of the nature of the anatomy and the extent of the territory that might be affected.
Thanks, Dr. Dickert. Yeah, you're right. I didn't find a lot of information in terms of the timeline of when they were first initially diagnosed with heart failure. And again, they excluded patients with acute heart failure or patients who've recently been admitted for acute heart failure exacerbation. But that's a very good point.
Dr. McDaniel, sorry, I'd cut you off earlier. I don't know if you.
Oh, no worries at all. No worries at all. I mean, I agree with everybody. I guess I would just say to echo what folks have said, I think the gut in the community is to do early diagnosis and do early revascularization. And this doesn't mean you should never do it, but I think it should caution us and just be a little bit more conservative about when we make diagnoses, how we make the diagnoses, and certainly putting a lot of emphasis on upfront medical therapy. And the last comment I would just say is that this is another caution of us using observational data. I think the field of medicine is filled with observational studies that have told us different things that are completely counter to them when we do randomized trials. Now, it doesn't mean that the randomized trials are right or the observational data is wrong, but we need both of these data to make good decisions, because we often find that what we see in observational studies is not what we see in randomized trials. And so we have to really applaud these authors for doing this study. Hard to do, but so important. And we need another one just like this.
I want to thank everyone for tuning in, listening. That was an excellent discussion. A special thanks to Dr. McDaniels and Dr. Sindasera, who helped me review my slides and with the discussions. And that's my dog.
Excellent. Thank you, Annie. All right. We'll move on to the next study. I mean, this is a study I think we could sit here and talk about for a significant chunk of the morning. So I think obviously an interesting study with a lot to chew on and talk about. And thank you, Annie, for a wonderful presentation. And now you can unshare your screen. We'll let Terry come on in here.
Morning, everyone. Sorry, my presentation is not going to be as sexy as Annie's, but I think mine is somewhat pragmatic. So I'm going to talk about acetazolamide for acute heart failure admissions. It was a study that just came out in the New England Journal last week.
Terry, go ahead and put it out. You're not on present. Yeah, go ahead and present.
Oh, presenter. There we go. Sorry about that. It was an article that came out in the New England Journal last week and was presented last month at the European Society of Cardiology. I have no financial disclosures. Diamox is not paying me. This is a lot of bullet points to highlight heart failure admissions are common. The goal is to get volume off people. We know diuresing people doesn't save lives, but it improves morbidity. Big trials in the past have showed that, not everyone is decongested in the first coming days, such as the DOSE trial showing only 15% were decongested in the first couple of days. There are registry data showing that discharge body weights, actually increase sometimes. And most of what we do in the hospital is either based on loop diuretics. When we do think of sequential nephron blockades, we usually add a thiazide or thiazide-like diuretic acting on the distal tubule. So this study was seeking to look into whether or not attacking that proximal tubule would be helpful in terms of diuresis. There is some non-randomized trial data that would indicate that sodium excretion in the urine is increased with acetazolamide being added to your diuretic regimens. And that was kind of a hypothesis generating for this trial. Guidelines recommend diuresing to euvolemia by discharge, both here and in Europe. And, if we discharge people with volume on board, there's still they will suffer from adverse outcomes. Method of action, as we talked about, acetazolamide is going to act in this proximal tubule. It's a carbonic anhydrase inhibitor. This is where most of the sodium chloride is excreted. That being said, if we can not reabsorb that sodium as we normally do in a functioning body, we would think that between that and the loop diuretics could increase your urine sodium output and thus decongest patients better. A point I will come back to at the end is SGLT2 inhibitors also act in this proximal tubule. So this is kind of just screenshots going through the supplementary information for this article, talking about the primary endpoints and objectives. Essentially, they wanted to see if by day 3, patients could be decongested more effectively by adding acetazolamide. How they defined it, if you look at these bottom bullet points, this up in this top block here, the way that they assessed patients for volume overload persisting was mostly using peripheral edema. They would also do an ultrasound of the belly, see if there's ascites, and they would also do an ultrasound of the lungs to see if there were pleural effusions. They had a scoring system for this I'll go over shortly. Secondary endpoints they were looking at were adding mortality and readmissions to the study, also quality of life, length of hospitalization. Safety endpoints, they looked at pretty much electrolyte derangements, creatinine doubling, and hypotension as what they would use for cutoffs. They had pre-specified subgroups. They included based on sex, based on less than mildly reduced EF or greater than mildly reduced EF at 40%. They had all the baseline characteristics you would anticipate in the study. Inclusion criteria, these are your standard inclusion criteria for a heart failure study. Points I'd like to point out is they made sure that they had a BNP level that was over 250 or an NT-BNP greater than 1,000, that they had an echo in the past 12 months. These were not new onset heart failure patients. Patients had to be on a standard dose of diuretics and had chronic heart failure to be included. The conversion factor they used for the study was if a patient was on 1 of Bumex, that was equal to 140 of furosemide equal to 20 of torsemide. Exclusion criteria, they were looking at, congenital heart disease patients. So sorry, Dr. Jokadar, I don't know if this is applicable to your patients, VAD patients, cardiac transplant patients. So some of the heart failure folks, I don't know if this will be applicable. Low GFR, systolic hypotension, less than 90. So our dialysis patients who are midodrine, I don't know if they wouldn't because it's a diuretic study. And the most pressing I wanted to point out for an exclusion is this study was ongoing as SGLT2s were coming to prominence. And also because of the method of action where SGLT2 inhibitors work, they were excluded from the trial. So by the time you went through the inclusion and exclusion criteria, we got to patients who about 250 of each that were admitted and had follow-up through 3 months. This is a nice slide, but doesn't show up well here. This is a different version of it showing the study protocol. So when patients would be admitted, if they met the inclusion criteria, they would get 2 times their home dose of oral diuretics as an IV dose, plus 500 of acetazolamide intravenously. On hospital day 2, they would go back to a total daily dose of IV diuretics equivalent to your home oral dose, albeit they would be split out over twice daily dosing. And they would do the same on day 3. And they would do their assessments on the daily basis, which we'll go over in a couple of slides for their scoring. Day 4 onwards, if you still had volume overload, they would consider escalation therapy per the physician, and that was either doubling a loop diuretic dose, adding a further sequential nephron blockade with chlorthalidone, or switching to ultrafiltration or some sort of CRRT. This is what we were just talking about, 2 times the daily dose on day 1, and then 1 time the daily dose for 2 doses on day 2. Their conversion factors similar to the dose trial, are 1 to 20 of Vumex, 20 of torsemide, and 40 of PO Lasix are all equivalent. However, they don't dose adjust for Lasix, PO to IV. Some people, I think, would say that 40 of oral Lasix is equivalent to 20 of IV Lasix, but that's different than what we see in this study. This is just showing they monitored the different GDMT patients were on. We must remember, though, in terms of the numbers, once we see them, that these were HFpEF and HFrEF patients. So not everyone was on full GDMT. And essentially, this is what I was saying. Every day they would see, do they have lower extremity edema? Do they have pleural effusions? Do they have ascites? If so, they're not decongested, continue diuresing. If they do not, then it's successfully decongested. And this is a score they would use based on how much of a pleural effusion, how much of ascites, or the amount of edema in the lower extremities. Like we talked about, that they would end it for electrolyte derangements, blood pressures changing, and creatinines doubling. In the escalation therapy, this is a repeat slide, adding the chlorthalidone, doubling the loop, or going to ultrafiltration. Background therapy, interestingly, they had, like, on a daily basis, these patients receiving some sort of formulation of potassium and or bicarbonate solution to ensure that their electrolytes maintained normality. This is different, I think, than I've practiced in the past. I've always replaced potassium or magnesium. However, it looks like they were replacing sodium bicarb as well. They also, a point to point out is they would not allow titration of the neurohormonal blockade, your ACE/ARB, ARNI, MRA, and beta blockers during the 3 days. So to go to our table 1, we're seeing these are older patients, upwards of 78 years old, predominantly men. This was ongoing in Belgium, so they're very white. That being said, it was about a 50-50 split or so of EF greater than 40% versus less than 40%. These were predominantly class 3 heart failure patients, a good split of ischemic versus non-ischemic. And, like I was saying before, these were HFpEF and HFrEF patients, so not all GDMT was included. And we see that, about 50% of people were on an ACE, 80% on a beta blocker, about 40% on an MRA. And obviously, because of the study inclusion criteria, 100% of patients were on a loop diuretic to begin with. During the study, we saw, patients were at randomization, usually getting about 120 of Lasix. This is just a breakdown again of the other GDMT neurohormonal blockade patients were on. And the money shot for this study is, what we saw is an improved improved removal of volume from patients at hospital day 3 when you used acetazolamide versus placebo. The congestion scores went down, and if patients did not get decongested by day 3, if they used the escalation protocol, there too, with a longer hospitalization, they were more successfully decongested as well. So that was the crux of this study. When they looked at, and that was a risk ratio of 1.46 with a confidence interval of 1.17 to 1.82. Secondary outcomes for this study, when they started adding in the mortality, that it didn't seem like it was a significant difference, but that's not surprising, I think, with the remainder of the heart failure literature, because we know that diuresing doesn't improve mortality, but it is going to improve morbidity, and these patients are admitted a lot, so that is something to be hang our hats on, I think, from this study. These are just more of the Kaplan-Meier trend showing that, death and all-cause hospitalizations were not any better with this study. Mortality was no better. Rehospitalizations were no better. And then when you looked at the pre-specified secondary outcomes, it looked like all groups tended to trend towards being better with acetazolamide. However, you see some of these people who are on baseline higher doses of diuretics, the equivalent of 60 of furosemide at home before, kind of closer to that center line. Lower EF starts to cross over versus your HFpEF patients, and females kind of crossing over that midline. That being said, this is a predominantly male study, so these are secondary criteria. So how much we could read into this is questionable, but thought-provoking. And last but not least, this was the hypothesis generating reason for this study was that previous studies had shown that adding acetazolamide gets you to cause diuresis natriuresis more appropriately or better, I should say. And we saw that again in this study. Authors concluded what we would suggest, more diuresis, natriuresis, faster decongestant, and shorter hospital stays, and there didn't seem to be higher incidence of adverse effects. Mostly men, these were, so patients had, EFs that were greater than 40%, which is higher, but similar to other trials. The ischemic cardiomyopathy in this trial was a little bit lower. Strength, large, it was randomized, it was placebo controlled. These are older patients that could be applicable that we usually don't have data on. Limitations, like we talked about, this is a single, European country with lacking diversity. Patients had to be on, at least 40 milligrams of daily Lasix already. So our new onset heart failures, I don't know that it's applicable to them, or possibly it is. I would like to hear what the group has to say about that. And, it's unclear whether adding acetazolamide to loop diuretics to thiazides altogether would be could be helpful. Again, the SGLT2 point, they were not included in this study, but it helps, I think, with confounding issues because they work on the proximal tubule as well. And then last but not least, these congestion scores were focused on extracellular volume, and we know heart failure is an vascular issue. So it's a surrogate, which I think is appropriate, but it's just something to think about. All that being said, a couple points I wanted to point out is, I've always thought of 40 of PO Lasix being equivalent to 20 of IV Lasix. However, this study uses a 1-to-1 ratio, and I think that's similar to the dose trial. And then last but not least, when you look at those pre-specified secondary stratifications, some of them don't seem as robust as others. So, but that could be hypothesis generating. Last but not least, whenever we're thinking about this sort of stuff, we want to make sure that it's cost effective. And here's from both UpToDate and Lexicomp, the pricing, they're exactly the same. But it looks like if we were to use IV 500 acetazolamide, it looks like the dose is about $40 to $50 per squirt. So in a couple $1,000 hospitalization, I don't know that 3 days of acetazolamide, an extra $150 will make that big of a difference, but just something to throw out there. So I'd like to open it up to everyone, see if there's any thoughts, questions, comments, or concerns.
Thank you, Terry. So in summary, given patients 2 diuretics instead of 1, diuresis them faster.
Yes.
Exactly. But it's fairly, and I guess it's fairly, I guess obviously what they're looking for is that it seems to be relatively safe. It did not give too many people like significant renal failure compared to just loop diuretics. All right. Dr. Smith, hand is up again.
My hand must have still been up from previously. I don't know. But I would comment that, we've been involved in numerous studies of inpatient therapy for heart failure, which have helped define some of the things that we've done. But in general, those trials have really just been negative trials. So for instance, aquapheresis with the CHF Solutions device, is not better than giving intravenous diuretics and that type of thing. So this is at least from the endpoint, this was a positive study. So I think it's kind of interesting. And the other comment is that our practice of in diuretic resistance of giving thiazides is, the data on metolazone and is if you actually just look at data on that, it worsens outcomes overall. That's not to say that we don't have indications where we need to use it, but a lot of the stuff we do on the inpatient basis, we don't really know what we're doing. And I think we'll be looking over this study and seeing if we modify our practice in some way.
Dr. Morris.
Yeah, thanks, Andy, for those comments, and thanks, Terry, for the presentation. I have two comments. One, I found it interesting that they use this congestion score as an endpoint rather than a change in pro-BNP, even though they required elevated pro-BNP to get into the trial. I thought that was interesting. And then I guess sort of similar to Andy's comments, I think this is interesting. I think it's important to show data that you can utilize quote unquote high dose diuretics. And I say that sort of on purpose, putting this in quotes, because I think compared to what we do in our patient populations, which obviously isn't necessarily based in data, but I think, we double and triple whammy people all the time, a la Dr. Srescu, and it's relatively safe, assuming that you're watching their electrolytes. I think Andy's point that using high dose thiazide diuretics has absolutely been associated with worse outcomes, but sending people home wet, as you pointed out on your first slide, is also associated with worse outcomes. So I guess my point is that I don't know how to apply this data to our patient population, because I think our outpatients tend to be on much higher doses of oral diuretics than what you're seeing here. And then I think in our patient population, because there is so much diuretic resistance, there's often sort of a need to use sequential nephron blockade. So I'm not really sure how this applies to the folks we take care of here, but it's good to see that it's safe.
Dr. Dickert.
So I'd be interested, so I would echo both of those points. It seems like this is a tool that it gets it on the map. So I actually do think it's a helpful tool for us to think through. My question for Terry and for maybe others, the part that I'm really having a hard time with this study is that the reason we care about effectively decongesting people is because we think that's going to translate into keeping them out of the hospital. That showed a really marked, regardless of how you assess it, it showed an apparent, pretty impressive reduction in congestion in the intervention versus the placebo, and yet they saw no impact on rehospitalization. That really seems odd to me, and I'm wondering whether, I don't know if they reported it, but is it possible that people in the intervention arm wound up underdosed in terms of their home maintenance diuretics, or some other alteration that we could potentially get on top of? Because that's just like a big wet blanket on the study to me, is that the thing that we should have seen short-term reductions in rehospitalization if we're effectively decongesting people. So I don't know if there are any thoughts that people have about why we didn't see that. Mortality you'd never see, but we should see something.
Yeah, I guess that was the underlying sort of thing behind my slight dig at the beginning. There was like, I just don't know if this was exactly the right endpoint. I guess it's just the endpoint they had to do sort of first, is to prove safety, and maybe next you do rehospitalization or something along those lines. But
if they were looking good, it's possible that one of the things we did is we thought they were doing great. We were giving them another medicine and we forgot to up their other diuretics. I mean, it could be an explanation that isn't about the therapy not working, but rather about the way that people were taken care of.
I also, Dr. Dickert, I think that's a great point about the rehospitalizations, and something that I couldn't quite understand, at least from the way that we practice here, is usually when patients come in, we double 2 to 2.5 their home diuretics, like the dose trial would teach us, and we persist with that until we switch to orals or something to that extent. But this trial, the fact that they did a double dose on day one and then split it to a single dose twice daily, like, it's not uncommon for us to use 200 of Lasix twice a day, and that's more than a home dose. And the way the study was designed is they wanted it to be based on your home dose of diuretics. And if you're getting admitted to the hospital with heart failure, often it's because your heart failure is progressing and you're no longer responding to your dose of diuretics. So perhaps, if your starting point is that home dose of diuretics and that is inadequate to begin with, maybe if we would have used higher doses than that, it could have been helpful for rehospitalizations. I don't know.
Hey, it's Raja Laskar, and first of all, this is a very sexy topic, Terry. I would come on. It's much more interesting than revascularization, but just to push back a little bit on Dr. Differ's comments, that to my knowledge, there has not been a clinical trial for decompensated inpatient heart failure patients which showed any of our therapies decreasing rehospitalization, and that's a hard endpoint to find out. So, but what the dose trials show, this trial showed that certainly you can get more volume off. Whatever is safe makes sense, but as Dr. Smith said, there have been lots and lots of clinical trials attempted. A lot of our guideline-directed post-discharge monitoring, patients need to be seen within a week or two or a month, phone calls, none of those have been shown. Phone calls by nurses, really kind of heavy lifting by staff. None of those have been shown to decrease rehospitalizations, unfortunately. So that is a hard endpoint to prove.
Thank you. Good comment. I see Dr. Abdu's been waiting patiently with his hand up. Quickly, as we're running out of time, Dr. Abdu.
Yeah. Actually, I was going to lower my hand because the comment by Dr. Laskar, that's exactly what I was going to mention. And Terry, good job. I think your presentation was very nice, and it's a very interesting paper that came out. And what I take from it, I don't think it will necessarily change my practice, particularly in how to diurese patients with acute decompensated heart failure. However, I will take this paper's results, and as you know, it kind of confirmed what I thought it would be in terms of safety of using acetazolamide in selected patients. I do use it. If you recall, when we're on service, I do use it selectively in certain patient profiles and certain metabolic profiles and so on and so forth. And anecdotally, it does work, and it does augment my diuresis. So I would take this study as a kind of a proof of safety of using the drug, and a relatively inexpensive medication and very safe. But thanks for it. And yeah, my comment was exactly what Dr. Laskar was going to mention. So I'm going to lower my hand.
Dr. King was next up with his hand up.
Oh, hi there. I'm not going to give you any wisdom here, but the only thing I ever used Diamox for was to prevent headaches when I went skiing. And I'm just surprised that in Belgium, there were no side effects because it makes your beer taste really bad. And and they drank a lot of beer in Belgium. So I just questioned this whole trial based on that fact.
And no mountains in Belgium that I recall.
No, it may work better in Denver. I don't know.
At low altitudes. All right. Well, for those of you others that have their hands up, I'm sorry, but for sake of time and everybody has to get on with their day, I think we'll wrap it up here. I want to thank Annie and Terry for their presentations, and look forward to seeing everybody next week. Thanks, everybody.
The preceding program is copyrighted by Emory University.